It's a pleasure to introduce Professor Marc Michel, who is Head of Department of Internal Medicine at the Henri Mondor University Hospital in Paris. He's been working on ITP for many years now and is actively involved in clinical research, including trials of novel therapeutic agents such as ianalumab and many others. And he's going to focus today his talk on TPO RAs as the first-line therapy for ITP. Marc, sorry for the slight delay, but the floor is yours now.
Thank you very much, Drew, for the kind introduction. I hope you hear me well. Thanks, Thomas, for the invitation. I wish I could be in Burgos with you, but it was kind of busy period for me. So these are my disclosures. So a brief reminder of the natural history to begin with of ITP. As you know, the main difference between childhood ITP and adult ITP is that the onset and the outcome of the disease is chronic in about 2/3 to 3/4 of adults. And I'm going to talk a little more about this natural history, specificity, and the rate of what we call spontaneous remission in adults, that a concept that we have to take in mind whatever treatment we use first line. So this is a bit old study, but still interesting, from Dr. Seiler from Austria, reported back in 2006, reporting the outcome of 114 adults with ITP before they underwent splenectomy. So basically, half of the patient had insidious onset, whereas 44 of them from this series had an acute ITP onset. The observation time period was 3.3 years. And basically, to make a long story short, what this study provided as information is that within the first 6 months from ITP diagnosis, the incidence of complete remission was 5% per month, whereas after beyond 6 months and between 6 months to 3 years, we were still a small but not insignificant rate of 0.5% of spontaneous remission that occurred every month. Beyond 3 years of ITP duration, year remission were really uncommon. Almost all patients who achieve a complete remission had this remission sustained for 5 years, even if very few relapses occurred. And in terms of differences of patient baseline characteristic, what this study showed also is that patients with an acute and highly symptomatic ITP onset were more prone to achieve spontaneous, durable remission. In a French study, a prospective cohort focused on clinical features and predictors of outcome. There were 102 adult patients, and among whom 43 achieved a remission after being exposed only to non-disease modifying drugs or procedures. And again, here, patients were more likely to achieve spontaneous remission if when the severe bleeding was more prominent at disease onset in favor of acute and recent ITP onset, and the platelet count was significantly lower in patient at time of diagnosis, in patient who eventually achieved a durable remission. So overall, up to 42.5% of the patients from that cohort were in disease-free remission at 1 year. So brief summary to that first part, whatever treatment used, first line could be Dex, prednisone, IGIV as frontline therapy. The rate of durable response is about 30 to 40% of the patients. Among patients who achieve, let's say, a spontaneous remission, only a few of them will relapse over time. So most of these patients will be eventually cured. This rate might be kept in mind now that several new therapeutic options and strategies are developed. An abrupt onset of ITP with severe bleeding manifestation is likely to be associated with a higher rate of spontaneous remission. And although this last parameter is a bit controversial, some studies have also shown that positive platelet autoantibodies at ITP diagnosis by means of MIPA are associated with more significantly associated with a chronic outcome. So if we move to the first line therapy, as you know, this is a slide from Walid. He presented at ASH last year. First line therapy, as everyone knows, is based mainly on corticosteroids, whatever type, and or IVIG and TPO RA are mostly used as second line as corticosteroid sparing agents so far. So this is a graph showing a figure showing the development, the historical development of TPO in Europe, starting from romipostine back in 2008 and ending with avatrombopag, which was the last TPO license for ITP in Europe. I'm not aware of a license of atrombopag in Europe, but I might have missed some information. So again, here, this is well-known data. I mean, the advantage and the pros for the using TPO in ITP, whatever the stage of the disease, is a high rate of efficacy, a treatment-free response in about 30%. I will go back on that. They reduce bleeding, of course, the need for rescue medication. And when one patient does not respond to a TPO array or does not tolerate it, the switch is possible and is actually effective in about half of the patient. Limitation is that in most of the case, TPO array are still, are still viewed as a maintenance therapy. They are rather costly, from let's say 50,000 to 40,000 euro a year, depending on which TPO array and the dosing. There might be some dietary restriction with a trombopag, and there is also a slight increase in the rate of thromboembolic complication in patients exposed to TPO in a recent large-scale study by Guillaume Moulis on the Common French Registry. Patient not exposed to a TPO array at all had an incidence rate of 4% of thrombosis, which is the usual and common rate of thrombosis in the ITP setting. And this rate rose up to 8% in patients exposed to TPO array. So when TPO array are currently commonly used, this is also a study, a collaborative study throughout the ERSI group, led by Guillaume. He pulled the data from different registries from the UK, France, Italy, Norway, and others. You see UK, more than 3,000 patients in the UK registry. And basically what we can see is on the left-hand side of the slide that the rate of using TPO has significantly increased from the 2010s up to more recent years, and that's, a common trend in every country, and specifically for L-trombopag, that is the most used TPO array in Europe. And when we focus in different country, UK in blue, France in orange. We see that L-Trombopag is by far the most preferred second line currently in those countries. There is an exception. Rituximab is still largely used in Norway, specifically, and more generally in Scandinavia, whereas the rate of using rituximab has decreased in other countries, also because of the pandemic in the last few years, which has led to a decrease of use of rituximab. So when and is there a rationale for using early on upfront TPRA in the setting of ITP? This is a retrospective study by our center about the use of TPRA as a rescue therapy. This, I mean, could be, there is room for using here ramiplostim for rescue therapy in patients with ITP not responding to corticosteroid and IVIG. Of course, in that situation, you need to make sure to rule out differential diagnosis, make sure this is truly ITP. And here we compared patient with severe bleeding, a platelet count below 20,000, not responding to corticosteroids and IVIG. To whom we gave ramiplostim plus vinblastine plus IGIV, corticosteroids, and platelet transfusion compared to an historical series of patients at the pre-TPO-RA era who got corticosteroid IVIG in combination with vinca alkaloids. So basically what we could show is that by adding ramiplostim at the maximal dose, 10 microgram per kilo, the overall response reached 70% in this patient population, with a 60% a complete remission on day 7, sorry, and 80% of overall response on day 14. In terms of safety, though, we did observe 2 thromboembolic events, one pulmonary embolism on day 4, post-ROMI and IVIG, in a patient with mild thrombocytosis, and one transient ischemic attack. 9 patients eventually had thrombocytosis after the combo therapy with IVIG, ROMI, and vinca alkaloids, and there was one death that was not related to treatment or ITP. So there is somewhere here, this is, I mean, provides some evidence for the possible use of TPRA at a high dose in very specific situation, life-threatening ITP in patient not responding to either corticosteroid and IVIG. The second, let's say, piece of evidence for promoting the earlier use of TPRA in adult ITP is, of course, the possible achievement of what we call SROT, sustained response off therapy. I here in this table summarize the 3 prospective studies that have explored the rate of SROT. So the first was from Francesco Zaia group and Elisa Lucchini, based on L-Trombopag, that was given for at least 24 weeks as a second line. 51 patient with a median ITP duration of 18 weeks. And basically, there was tapering indications according to a specific tapering regime up to the discontinuation. And overall, the rate of SROT that they found was 38%. Then there was the Stopago French multicenter prospective trial. Here, the population of patients was a bit different because only patients who achieved a stable, namely at least for 2 consecutive months, complete response on either L-Trombopag or ramiplostim were included and start tapering. 48 patient, as you see, a patient that was really different in terms of patient profile and ITP history compared to the Italian. Median duration of TPO exposure was 1.6 years, and in median they received two previous treatment lines. So most of those patients had chronic ITP with a long exposure and a very stable, good and complete response on TPO array. And here in this specific population, the SROT at week 24 was as high as 26%. And we have recently updated the data with 4 years of now follow-up. Only 2 of the initial patients who achieved SROT had relapsed, meaning that the SROT at 4 years of follow-up was still very high, 50%. And the last trial you're aware of is the TAPER trial promoted by Novartis. Here again, focus on eltrombopag. The inclusion criteria was somehow intermediate between the Italian and the French study. Patient had to achieve at least 70,000 platelet count for at least 2 months before starting the discontinuation. 105 patients, almost half of them had a newly diagnosed ITP, and here the SROT rate was 30%. None of the studies were able to identify a specific marker or parameter that may predict the likelihood of SROT. There is a signal in the French study with a marker which is the expression of CD69 and CD8 positive T cell, which was significantly higher in patients not achieving SROT or SCROT, which is sustained complete response. In this population, we are, and specifically Mathieu is currently working on the significance of this marker, and we expect more data in the future. There are much more less data with romiplastin. There is a Danish study, the cohort study, but it's observational. It's not a prospective trial for focusing on romiplastin. Some patients were exposed earlier during the course of the disease, and they reported a 40% SROT rate with romiplastin. So basically, the summary of this second part is that overall, about 30% of adults with ITP may achieve SROT after being exposed to TPO RA single therapy. Most of the data available are actually with eltrombopag. The likelihood of achieving SROT is higher in patients achieving initial stable CR, and it seems that the overall rate of SROT may also be increased with the time of exposure to TPO, and mostly in patients with chronic ITP, although this data is a bit controversial. There is no robust and validated biological marker or tool helping us to predict the outcome, and tapering and possibly stopping treatment with TPO is, of course, worth trying in patients with stable response. But there is no consensus of the optimal duration of treatment and platelet count before tapering. Thomas provided some, let's say, the Burgers discontinuation protocol, and Francesco also and others have reported some overweight to taper and discontinue eltrombopag, but none of them are consensuals. So let's now finish with the few studies that have explored the efficacy of using as frontline therapy TPO. This was the first one, the Mexican study, open label, single arm, patient with newly diagnosed ITP were treated with oral dex for 4 days, plus eltrombopag for 4 weeks at 50 milligrams. And basically only 12 patients is a small study. All the patients achieve initial CR or PR, and eventually on follow-up, 4 of them had a relapse. Median platelet count of diagnosis was 7,000. So basically, 4 patient relapse after a median time of 14 weeks among the initial responder, leading to a response-free survival rate of 60%. The second study was reported for a Chinese group. Again, here, phase 2 single-arm open pilot study. Treatment consisted of eltrombopag at a dosing of 25 up to 75, according to some dose adjustment and initial platelet response for 12 weeks this time, plus pulsed dex for 4 days that could be repeated up to 3 courses. You have the flow chart here, and basically 46 patients were evaluable and included, and their durable response rate was 56%, which by the authors was significantly higher than the expected and assumed response rate when using only dexamethasone. The third study I found in the literature was again a Chinese study assessing the efficacy of eltrombopag plus transient use of corticosteroids. It's an uncontrolled study. Patient at a baseline platelet count which moderately low, between 30 or between 50 with significant bleeding, and they receive corticosteroid regimen according to the weight for 3 weeks, and in combination with low-dose eltrombopag, 25 milligrams, that can be effective in a patient of Asian ancestry, and decrement of eltrombopag after 12 weeks of exposure up to discontinuation. 6-month follow-up, 22 subjects completed all studies, and 9 patients were able to achieve eltrombopag discontinuation. So the initial rate of response on corticosteroid and eltrombopag low dose was as high as 100%. I'm always a bit skeptical when I see 100%, whatever the study, as initial response. And SWOT was eventually achieved in these studies in 27% of the patient. If we consider every patient, including 33 initially, and up to 42% per protocol, leading to a relapse-free survival probability of 83%. So the author concludes here that this strategy could potentially represent a viable first-line treatment option that require validation in randomized trial. There are other trials currently ongoing, mostly from China and Germany. One is in Germany, promoted by Novartis, again, testing the hypothesis of a high efficacy rate by combining either eltrombopag or romiplastin with dexamethasone as first line. So to conclude, based on what we know from adult ITP natural history and the data from the few phase 2 open trials, the early use of TPO RA in combination with a short course of corticosteroid may increase the rate of lasting/durable response of therapy. But in my opinion, there is no robust evidence in the literature so far, because we lack RCTs in that specific setting to promote the large and wide use of TPO RA as first-line/frontline therapy. Of course, if some easily and available predictors of SWOT could be identified in the next future, this could encourage early use of TPO RA, either alone in patients with no or moderate bleeding manifestation, or in combination with a course of dexamethasone. And with that, I thank you for your attention. I will be happy to take questions.
Thank you, Marc. Thank you. Actually, while we think of questions, I think one source of data for upfront use of TPOs would be the pandemic, when most countries, we certainly got permission to use TPOs first line during like 2020, 2021, 2022, and then it was withdrawn from the National Health Service, and other countries, I guess, will have used TPOs right up front in newly diagnosed ITP. So maybe we could get something from the French registry, the UK registry, and anyone else is capturing these data. Mark, do you think it'd be useful information?
Yeah, I mean, we definitely have some patients who have benefit from the very early use of TPO during the pandemic, also afterwards. Well, mostly in my, to my knowledge, patients who were really severe, highly symptomatic ITP, for whom we needed, I mean, to increase rapidly the platelet count, and let's say a rescue setting for maybe a short time use. But I don't know if Guillaume is in the audience, but he might have over information based on the very large Carmen registry. So, I mean, the other possibility is that we sometimes, as you are dealing with adult patient with insidious onset with fortuitous discovery of a low platelet count after a rapid checkup and blood work. We make sure this is ITP. They're asymptomatic, but still they have a platelet count lower than 30,000. And in such patients, where for whom we don't necessarily need to use steroid up front, some of them are actually receiving as first-line TPO alone, considering that probably the history of ITP. I mean, they have already persistent chronic ITP. But what I meant, I mean, is that we really need to keep in mind that some patient will be remitting whatever we use, so not to overestimate the impact of early use of TPO and in that setting, we definitely need a randomized study that has not been performed so far.
Great. Okay, Waleed. Waleed is next.
Hi, Mark. Very nice talk.
Hi, Waleed.
Mark, would you be worried about the risk of venous or thromboembolism in general? I mean, in the TAPER study we had, it was used as an early second-line treatment, L-Trombopag, and we had 6, I think, thromboembolic events out of 100 patients or something like that, 6%. It's a similar population giving it early. So exposing these patients to risk of thrombosis, that's one thing. The other is the fluctuation, the overshooting when we combine TPO with steroids. I mean, I don't know, but we should wait for the randomized trials, but what are your immediate thoughts of?
Well, to me, it's always, thanks for the question, Walid, it's always a matter of assessing the benefit of a risk ratio on the individual basis. In a patient with life-threatening hemorrhage, I don't have major concern about the risk of thrombosis because I think the risk of bleeding outweighs the risk of thrombosis. In a patient with no severe ITP, of course, if I had to use TPO array earlier on, I would probably before at least check for the presence of antiphospholipid antibodies, and I would be more reluctant to start early on TPO array in a patient with a history of thrombosis for sure.
Okay. I think one of the other things what I like about upfront TPOs is irrespective of whether remission rate is higher or longer. It's just the reduction in the steroid use and the morbidity that comes around from the long-term steroids. So just 1 week of steroids is really, really attractive. So I think that alone sells it to me.
No, I mean, I agree. I mean, sparing steroids it must always be a goal we need to achieve and to focus on. But basically, beside, I mean, the license and official indication, uh, if we have to start TPO RA first line beyond the sparing of corticosteroids, I think that the goal should be to try to taper, to find the minimal effective dose for pharmacoeconomic reason, and eventually and hopefully to get rid of TPRA if a SROT is achieved. So it could not be viewed as like a long term. It should not be viewed as starting earlier, a long term maintenance therapy only.
Okay, thank you so much. I think if there are no further questions, I'd like to thank Marc for a very nice talk. Give us something to think about. Thank you, Marc.
Thank you. Have a nice meeting. Bye.